Good afternoon, everybody, and welcome to another edition of the New York HIMSS chapter virtual events. Today we'll be discussing activity-based costing. It is here, it is real. Next slide, please. A little bit on the logistics here for folks. This way you'll be able to, if you have any Q&A, come through our chat line. And during the course of the conversation today, we will try to answer as many of the questions as possible. If you run into any technical difficulties, you can just click the refresh, come in through your web browser, and start over again. This will be recorded, so you will be able to view it at any later date and time in the future. Next slide, please. We're always interested in increasing our membership. So become a member of the New York State chapter. It's real easy, real quick to do. Come and join us. This way you'll be part of all these exciting events that we're putting on and all of the education that we provide to our membership. Next slide, please. And you can connect to us in multiple different ways, through the LinkedIn page, through Twitter, through Facebook, and also through all of our email channels. Next slide, please. Let's thank our sponsor for today, Health Catalyst. If you're interested, do a little read up here, and you'll be able to get in touch with them by just following through the information that's located on this page. Next slide, please. It's my pleasure to announce our speaker for today, Mr. Mike Andrews, who will go into full detail with his presentation. Please give him your undivided attention. Mike, take it away. It's all yours.
Oh, thank you, Anthony. Thank you very much. As he mentioned, we're going to talk about activity-based costing, and you might think to yourself, well, that doesn't sound too IT to me. And on the surface, you probably are correct. But I believe that this is going to be an opportunity, if you listen and learn, that you can find a way to, another way that you can prove ROI for your EMR. A lot of acronyms there, but good activity-based costing really uses the EMR, and I'll get into that. And so we think there is a definite IT angle, as there's always pressure on IT staff to justify the EMR spend and ongoing spend. And here's one of these great ROIs for that. So my agenda for this afternoon is I'll probably do a little preaching to the choir. I'm from down in Texas. You're going to hear some folksy things probably. You'll hear me say y'all a couple of times, I'm sure. There's some, the challenges are going to be preaching to the choir. I'll talk about what activity-based costing is and how it does work with the EMR. I do have some case studies and some sample reports. And as Anthony mentioned, I'll leave time for questions at the end, but please do hit me in chat. And if I'm not getting to the chat, somebody prompt me, and I'll make sure I try to get to it ongoing as we can. So here's some of that preaching to the choir. If you saw quickly on the slide of my bio, I've been doing cost accounting for 39 years, both on the provider side and on the vendor side. And 3 years ago, just this slide would not have been involved. It's amazing who is taking over your revenue to a certain extent. You're getting revenue leakage, and it used to be, oh, I'm getting revenue leakage to ABC hospital across town. Well, that's still, of course, always going to happen. But now it's things here, Teladoc. The Amazon and Walmart are two of the top 3 employers of physicians in the United States. They're 2 of the top 5 employers of pharmacists in the United States. You've got vertically integrated insurers. You got Aetna with CVS Pharmacy. You're seeing all these other mergers. Optum and Change, things of that nature. My son lives out in Ventura, California, and he was feeling poorly. He did a Teladoc through his insurance, and then Amazon drone delivered his prescription to his doorstep. That's no involvement with the healthcare system that we know of at all. And so that's taking revenue away. So if you're getting revenue leakage to these areas, and I'm not saying these areas are wrong, it may be the new real. I think it probably is, quite frankly. You've got to be able to be laser focused on controlling your costs in an era where revenue is decreasing. And we know that government reimbursement is not keeping up. So that makes it, again, another whammy to the revenue side. So we've got to get to the cost side. And so, I mean, these financial headwinds, again, are things that you're not unfamiliar with. I will bring up labor productivity right in the middle. I just got through speaking in Houston at an HFMA chapter on traveling nurses and traveling nurse expense. And I'm a statistician, so I did some research, and this was in Texas, but I also did it for some of the other states, including yours. And basically for every 10 traveling nurses that you employ, as opposed to a full-time nurse that is on staff, it's costing your hospital between $1.3 and $1.8 million extra a year, directly off the bottom line. And I literally had somebody at a hospital in Houston say, well, we're now up to 100 traveling nurses. So, I mean, they did the math. It was like $13 million. And so they were just appalled. And now I'm seeing traveling radiology techs, traveling cardiac cath lab folks. And so as it becomes more of a traveling environment, so to speak, that's going to be big dollars. And so we've got to know where those people are being used and what they're being used for. The other things, I mentioned the payer shifts in the previous ones, and your volume's decreasing because it's getting siphoned back off to those folks on the thing there. There's all sorts of pressure on pricing transparency and regulation now that weren't there years ago. Point being, you got to really know your costs, because everything else is kind of crumbling a little bit around you in terms of finances. So here's the problem, though, with that. It's what I call the 4 A's. And those 4 A's, as you see there, are assumptions and approximations, allocations, and averages. The typical hospital does a great job of producing a financial statement. Here's how much money we took in, and here's what we spent. How much of it was labor, how much of it was supplies, how much of it was interest, how much of it was depreciation, the traditional accounting things. But they have no idea what a gallbladder really costs versus a C-section versus a pneumonia patient. They don't know what it actually costs. Can you imagine in any other business not knowing what your products cost? Because what they use is average costs. Because they, only cost out things that they charge for. And as we know, there's so many other things that happen to a patient that are not charged for. So that's mistake number one. And mistake number two is because they're doing this with averages, because they didn't have the actual data when virtually all cost accounting systems were created. In fact, I was talking with Anthony before we went on about mainframe cost accounting systems. They were there before EMRs, and most of the cost accounting systems were created in the late 90s, early 2000s. No EMRs to tap into. So they tapped into what was there, which was the billing system. Hence, they only cost out things that are charged for. And what they use is a concept called relative value unit, or an average. So they might go in back in the day, or even still to a certain extent, they would go into the EKG department and sit down, and I'll even use I'll go old school and use the term stopwatch, and sit down and stopwatch. How long does it take to do an EKG? They'll watch 10 of them being done and take the average of the 10 different times they saw. Then they'll do the same thing for the EEG and for the 2D Doppler test. And then the next day, somebody will go over to radiology and watch chest x-rays and knee x-rays, etc. Somebody will sit in surgery, and it's a repeatable thing that's done. It takes some time and it takes resources to do that, but then they come up with these averages. Now, when I was speaking to the CFOs down in Houston, I talked about, and some of them said, well, I get pretty good costs from that. I said, well, you're going to get a number, but it's going to be an average number. And I said that the easiest way for me to equate this in a non-healthcare environment is, because it was back in September when school was just getting started. I said, what if you took your kid and you went to go meet the teacher, your second grade kid, and the teacher comes out and says, I'm so happy to meet y'all. But you know what? I've been doing this for a while, and it's just a lot of work to get what you're, to have to grade each individual paper and test and see what your kid's actually doing. I'm just going to give everybody an average, an 84. I've seen this over the years. I know what that's about right. So all you kids are going to get an 84. But that's what they're doing right now in costing in hospitals. They're saying every person who gets an EKG, it's an average of 12.5 minutes, because that's what their averages of their 10 that they saw when they did it the day 6 months ago to develop the average. If you did that in a school and a teacher said that, the teacher would be in a lot of hot water. Yet, hospitals are doing that and making big financial decisions based off these averages. And the other excuse was, and I'll go to my next slide. And so we have 3 patients here. Let's pretend they all got a meniscus surgery, since it said procedure. Folks that are accounting folks, like I said, I'm a statistician, would say, well, the only way you can really do actual costing is if you have a manufacturing process where it's repeatable and it's the same. If I'm building a Ford Mustang today on the assembly line, other than maybe color of paint and a few options, the basic car is going to be the same, so that we can therefore come up with the actual cost of the basic parts, and then the optional features we would cost separately. But you don't do that in a hospital, they would say. Patients come from a variety of directions, and so maybe patient 1 came from, was a sports medicine clinic that referred them for the meniscus surgery. Patient number 2 would be more like me, and maybe it's just old degenerative knee. Went through my primary care physician, saw an orthopod, finally came to the hospital for the surgery. Maybe patient 3 was in an auto wreck. So all 3 came from a variety of directions, but they do all come for the same procedure. And in the past, you'd have to agree with that. Well, it's not manufacturing. There's no way we can get at this information. But now we've got that EMR. We've got all that data. So on the left, how people are doing costing in 90% of the hospitals in the United States right now, and around I'll just say 90% of the hospitals in the US. We'll come back to the rest of the world here in a minute. Is that, again, they have the same cost if the charges are the same. If they all have an EKG, the EKG cost is the same. If they all have a knee x-ray, the knee x-ray cost is the same. If they all have a 50-minute surgery for the meniscus, the OR cost is the same on the left. But because we can tap into the EMR, that gives us the activity, both chargeable and non-chargeable, and I'll hold the non-chargeable to the side for a minute. We can know exactly what happened. So if all 3 had a 50-minute surgery, the EMR will tell us that patient 1's OR nurses were younger and hadn't worked at the hospital as long and aren't getting paid as much. For patient 2, which is me, you had to use a much more seasoned anesthesia tech because I'm older, I'm diabetic, I have higher weight. And for patient 3, for the auto wreck, there was trauma nurses in there, so they might have been higher, but then on the other hand, the patient was in better shape, so they didn't have to stay, there's all sorts of variables there that you never know if you're just taking the charge of 50 minutes of surgery on the left. Take away the labor for a moment, then there's the supplies and drugs. On the left, all we know is that the surgeon used the standard OR pack that had been developed for meniscus surgery. That was what was charged for. On the right, it will be documented in the EMR and your OR system, if in case that's separate from your EMR. Every instrument out of that pack, that maybe that pack had 5 pieces to it. And patient 1's doctor, Dr. Smith, used 4 out of the 5. Patient 2's doctor, Dr. Jones, used 5 out of the 5. Patient 3's Dr. Harris, and Dr. Harris used 2 of the 5. Well, we know that now, and we know therefore the waste of supply that wasn't used. And we have all of that information. And so we have a much, much more granular view. And guess what? It's actually what happened to the patient. So 3 big benefits. 1, more accurate. B, much more accepted by clinicians because it's what they actually worked on versus something that's a charge, like a pack. And 3, you don't hear me talking about, for the actual cost on the right, people having to go out and take the stopwatch and figure out what the average time is. It is what it is for each individual patient. So as a result, more accurate, less maintenance, less time to do, and you have more accurate. So it is something that, because of the advent of the EMR, we can really go at this. And I mentioned non-chargeable. Let's talk about that for a moment. Take our 3 patients. All 3 had to get a knee x-ray. Well, I can tell you that me as patient 2 probably had to have 2 rad techs to get me up onto the table. I'm bigger. And maybe patient 1, post-operative, got back to the room, threw up a couple of times, so housekeeping had to come twice. Don't charge for any of that, but that's cost. But we know, again, who's involved. We know who pre-registered these people from your EMR. So we've got all of that information if we need it. And because of that, because of your EMR, this middle box is the big thing here. It becomes much more trustworthy data. I've talked about the accuracy and the speed just a minute ago, but you can be the fastest in the world. If it's not trustworthy, it doesn't make a whole lot of difference. And if you've got trustworthy data and accurate data, then you can start making some real informed financial decisions on service lines, on physicians, negotiating with payers. And I'm going to show you some examples of that. That's the big thing here is you know, I'm going to cut to I started with how do you butcher the cow? You can tell Texas. We're going to get to the steak here now in a second, the sizzle in terms of this. But, you know, real important that we understand that this isn't the end all be all. I'll give you another example of a non-chargeable that's was huge. I was mentioning traveling nurses and how much more expensive they were. And I had a hospital that the medical ICU was on the top floor, 9th floor of the hospital. And lab was on the 1st floor. So, you know, a patient, Mike Andrews, would need a blood draw. They'd call the phlebotomist, and elevators being so busy took too much time. Head nurse would finally just say, "Oh, Gloria, go down and take care, do Mike's blood draw." Well, Gloria is a traveling nurse. Turns out, you know, we are able to study, because we have the actual activity, thanks to the EMR, that Gloria did 5 of those during a shift. And they take about 10 minutes when it's all said and done, each. So 50 minutes of Gloria's time equals an entire 8-hour shift pay-wise for a phlebotomist. So the hospital actually looked at that, because we had that data, and actually in the medical ICU put a phlebotomist on the floor, so that at least either they reduce the traveling nurse need some, or have the traveling nurse do things that they were really brought in to do. Promise you some reports. So here's one. It's on hysterectomies and comparing laparoscopic, vaginal, robotic, and open. And I boxed the open because it's by far the highest cost, $78.93. And the hypothesis behind this was the robotic vendor came to them after a year, and the volumes are pretty good. I mean, laparoscopic still the highest, but there's enough at 330 with robotic that we have a good enough sample size that we can say that's about right. I mean, that's got to be pretty accurate. So we have this cost, and the robotic vendor came and said, you know, we think you probably need another robot, a second robot. And the finance department was able, because they had actual expense, including actually taking depreciation of the robot and allocating it directly to all the patients that got robotic hysterectomies. Well, you know, your cost is actually $2,400 higher than vaginal and $1,500 higher than laparoscopic. No, you're better than open, but you're not better than the others. And so the robotic vendor went straight to the robotic vendor's sales playbook and said, but our outcomes are better. Well, here's another advantage of a costing system or costing tools that are integrated with your EMR. All the ones that do the averages, again, they're only integrated with the charge master and the billing system. So they have no clinical data. I mean, yeah, they got the DRG and the ICD-10 codes and the CPT codes, and they've got, you know, demographic data, but they don't have true clinical data. They don't have quality data. They don't have outcomes data. So when the robotic vendor would make that claim to another hospital that didn't have activity costing, for them to be able to disprove or prove that, yes, it's better outcomes, they would have to go to IT and get somebody who's in clinical analytics to take a dump of these 330 patients and get their outcome data, probably in an Access database. And it's just another ad hoc report that's being shoved on IT and the analytics folks. Well, if you're integrated with your EMR data, and in this case, they came back within about 2.5 hours and said, well, guess what? You know, your length of stay is really no better than laparoscopic or vaginal. And your transfusion rates and complication rates and 30-day readmits are no better. So not only are you higher in cost, hold out open for a second, you're not any better off clinically, outcome, quality-wise. And we've got 330 cases, so it's not, you know, one outlier is not going to really knock this up, skew it. Now, yes, maybe do we get a second robot to eliminate open? That's a good academic discussion and financial discussion to have. But you would never know this if you didn't, first off, have accurate cost, and B, have clinical data at your fingertips that you can go right back to as you need to. I'll give you another case study. So this one's on lumbar spinal fusion. And as you can see, we've got the cost broken out by different areas. And you've got an $18,000 cost. But the problem is, if it was another costing system, you might come up with something close to 18,000. I don't know, maybe 19,000. I don't, you know, it's okay. But because you're having averages, all your cost at the total is an average of the averages. So you show no variations. You have no idea whether that average is tight, or in this case, as you can see, it's almost 100% variation. Look at the service center variation between 67 and 184, or just the supplies, blood, and drugs, 67 to 150, you know, 90% variation. So what we don't know, if I'm the CFO and I get this, I know that my cost for doing a spinal fusion is running anywhere from 10,000 to almost 27,000. How do I negotiate with Blue Cross a case rate for lumbar spinal fusion when I have such a big variation? Right now, they don't know the variation, so they have to basically say, how close is what I'm getting proposed to me to my average of my averages? And I better hope that it's tight, because I'm going to probably have to accept it. So this is where major errors are made, decisions are made, let me say it that way, that lead to financial folly because they have an average suppose Blue Cross proposed 20,000. Oh, I'm going to make almost 2,000 a case, but not for those ones that are 27,000. And they don't know, is that systemically back and forth? Is it Dr. Smith that's the high end and Dr. Jones is at the low end? If so, can we have Jones talk to Smith? Or is Smith both high and low? Is there problems there? The other thing I will talk about, which I thought was interesting here, that nursing costs were only 14%. This is a surgical procedure. So there's, the OR piece is going to take a bigger percent of total. But again, traditional costing systems use charge codes. I think I've said that about 23 times already. So for the patient day and observation day, that's the charge for the patient day and observation day, which is generally almost universally done based off midnight census. So the software is coded that wherever the patient is at 12:01, and if they're an inpatient, then it's a patient day charge for 3 West or 9 North or whatever it happens to be. Or if it's an observation, if they're outpatient, same thing, wherever they happen to be. And so then in the costing procedure for the traditional, there is an average cost or an average number of nursing hours for that day for 3 North, 5 West, etc. But if you've got great EMR data, you can actually look, as you can see over here under consumption driver for nursing, ADT minutes, time patient was in each bed, not number of room charges. And let me give you a real example of how that can make a big difference. I had surgery in June for my shoulder. And it was supposed to be really an outpatient surgery and go home. I, again, a little overweight, diabetic, and then I had an adverse reaction to my anesthesia. So I was actually placed in a surgical ICU post-operatively. I got in there at 10 in the morning. Surgery was done at like 7:30 in the morning. I was there for 12 hours. And then at 10 o'clock at night, they moved me to a regular surgical unit, 3 West, to spend the night, and I got to go home the next day. So 12:01 hits, and I'm in the regular surgical unit. So they actually get a charge for the regular surgical unit. So no time or productivity or cost for my stay was associated with the 12 hours I spent in the ICU. So we under costed the productivity and the cost overall for Mike for his shoulder surgery for the time in the ICU. Now, yes, there might be some that comes in the other direction where people go from a regular unit and then get moved up to the ICU at 10 o'clock, and so that they would get credit they didn't deserve. But there's not usually a lot of step ups. There are a much higher percentage of step downs. And in an era where we've got to really understand our nursing costs, not even recognizing them because the patient wasn't there at 12:01 is a really, it's an opportunity for expense failure, so to speak. The other thing that this variation really grants you is the ability to find out, where your outliers are. I'll tell you an off-slide story before we move on. I was working with a group of physicians, and it was in Texas. They were ophthalmologists doing cataract surgeries. They do other surgeries beyond that, but cataract. And between there was an ophthalmologist, and amongst them, they did about 1,000 surgeries every quarter. It's a pretty good volume. Quick surgery, 30 minutes. 95% of the patients were Medicare. Not a surprise. Medicare pays about $900 a case. And we were noticing that at least half the physicians were losing $300 or $400 a case based off cost. $900 revenue, but they were getting $1,200, $1,300, $1,400 in cost. So we were able, because we have all this detail, to dig in. I think out of the 1,000, I think like 12 patients had more than a 30-minute surgery. So it wasn't surgery time. And it's a minimal nursing staff needed for surgery because it's an outpatient procedure. So it wasn't the surgical nursing cost was not that different. Every single patient had the same eye drop. So from a drugs perspective, exactly the same. All but about 10 patients had 30 minutes of recovery room. So that wasn't it either. And then they go home. So what we got down to was between the 8 surgeons, they were using 5 different lenses. And the lenses ranged anywhere from $300 to $800. And so the physicians that were using an $800 lens could have almost been doing the surgery in the parking lot and they still would have lost money. And then when we dug further, the surgeon who was the highest volume surgeon had almost an equal number of patients, and I'll make up the number. Let's say that surgeon did, 150, that 75 were using the $300 lens and 75 were using the $800 lens. And because we had the clinical and quality data, as I talked about, everybody went home after 30 minutes. We looked back for readmits or complications, 0. So we went to Dr. Smith, who was doing the $300 and the $800 lens in equal apportionments, and said, hey, we've looked and you're using these 2 different lenses. We don't see any quality issues. And of course, the doctor said, of course not. There's no quality issues. These are great lenses. And I've been doing this for years, blah, 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 blah. And I said, well, did you realize that Acme lens is $300 and Johnson & Johnson lens is $800? Well, I had no idea. And we said, well, why are you using the 2 lenses? Well, I've known both of the vendors for a long time, and they've always worked with no problems. I just assumed they were all close to the same cost. No idea what the acquisition cost. And why would the ophthalmologist? The ophthalmologist recommends this is the type of lens I need. Then purchasing and supplies goes and gets it. And so here's a situation where it's not even an OR pack. It's just a lens. And so I'm not comparing Dr. Smith to Dr. Jones. I was literally comparing Dr. Smith to Dr. Smith. And so if I could take 150, even if I could take 100, I'll make my math easier. 100 of those surgeries and drop it from $800 to $300, it's 50 grand. For that one physician reaching to his right on the shelf to get the cheaper lens versus reaching to the left to get the more expensive lens. Now multiply that by 8 physicians. We came up with about $370,000 worth of cost savings every quarter. So we're looking at 1.5 million-ish for the year. And oh, by the way, when we went to the $300 lens company and said, we're going to bring all of our volume to you, they got a purchase discount, dropped it down to $270, another $30 times 1,000 times, it's 120,000 more to the bottom line. And I get stories after stories from clients talking about they're not having, and in this case, they did not have to rearrange the OR procedures. They did not have to rearrange the OR schedule. They didn't have to change any labor at all. There was nothing IT needed to do to make things different. All they had to do is change the vendor. And so we're finding that in OR packs, one I gave you earlier where somebody's using 5 out of 5 pieces, someone's using 3, someone's using 4. Redesigning packs because we know exactly what's being used. So there's less waste. There's so many stories where the bottom line is being affected positively without really having to change what's going on at the hospital. And that's because, again, y'all are curating and maintaining quality data in your EMR. So, here's an example where, I've got physician A versus B, C, D, E, F, G, H. And we can look at differences, and this is where we get down into those packs and those knives and those pieces and those parts. Or if this had been the if this had been the cataract surgery, we'd have had just the lens. So we can see those differences. And I really, really tend to stay away from, and I would just be a little bit of advice, staying away from doing this kind of comparison until you really analyze physician A against physician A and B against B and get them to be homogeneous to themselves. And then you can go tackle the A versus B and B versus C. Just a whole lot easier. You don't get the finger pointing. My patients are different if you're comparing physician A's patients to physician A's patients. And of course, you got to do it for a particular case type. So you'll be doing this analysis over and over again for different case types. And some people ask, previous screen, it says blades and knives and, instruments and things of that nature. You want to be able to get down to, and here it is in Excel, and you can download, most people are downloading into Power BI. And it used to be kind of Tableau and Click, but I think most people are going to Power BI because then they can get it in Excel, and a lot of people are pretty darn familiar with Excel. Or Power BI is similar enough. It's a cousin, so to speak. But look at, you can get down here to this explicit cost, and that is truly where these are the supply items that this patient 00536XXXXX. These are the supply items this patient had. These are if it was labor, these are the people that worked on you. These are the people that did your housekeeping on the 30th. These are the people that did your housekeeping on the 31st. Are they getting paid differently? So you know that data down to the nit and nat. And then that also, if we have that for each individual patient, then 00536 is a gallbladder, and the next patient's a C-section, and blah, 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 blah. Like all other cost accounting systems, there's really no differences here. You can sum those up to your defined service lines. So now I can start seeing trends of cost, and then I can cut it like you see up here. It said service line. I might want to do it by provider. You've seen me already show a graph where it was Dr. A, B, C, D. I might want to do it by diagnosis. I might want to do it by procedure. I might want to do it by payer. But I also have, beyond the traditional demographic and clinical, I've got all of my results data that, again, you would never have in a traditional cost accounting because I'm tied into the EMR. So now maybe I want to take my diabetics and I want to array them by A1C grouping. Those that are, have a high A1C, versus those that have a lower A1C but are still diabetic. Well, there's a big difference in how you treat an insulin diabetic versus somebody who's just taking metformin. And again, if you look toward the bottom, I can get to my exact direct drug, direct supply, direct labor. And then we can do the other allocations that most good cost accounting systems will do. So I know this for those different things. And beyond just the clinical data, because I have an unlimited amount of space, or so it seems, for EMR data, I can take on those, I don't want to call it wacky, but I'll give you a story. Had a hospital in a town that was 75% Catholic. This is going to be a good story. And it was Catholic hospital. And they were looking at their OB, women's and newborns, and we're really seeing losses. So they started looking, and they were running about a 45% C-section rate, which, the national average is 24, 25. Pretty appalling. So they start looking, and it's across the board. It doesn't really make any difference which obstetrician. They all were ranging anywhere from 40 to 50, 45%. So they looked by payer, and that didn't really make a whole lot of difference by payer. So, they were looking even at day of the week that the birth happened. Was there something that because it was on the weekend, they were doing more C-section? No, it was arrayed across Monday through Sunday. So finally they said, well, where are these patients coming from? And that's where it jumped out, that in a certain part of town that was lower socioeconomic, there was about a 60% C-section rate versus the traditional 20% in the rest of the city that were coming to their hospital. And so they were able to also, one of the things that the hospital did in their EMR and their admission data was that they would ask the patient, just like most hospitals do, what your religion is, if you care to give the religion. And if they gave them the big C for Catholic, and they were San Antonio, they actually had a pop-up box of all the Catholic churches in that town. And they would say, oh, which church? Oh, I go to, St. Joe's. I go to St. Alphonsus, whatever. And they would note that in the record. Well, they looked, and that part of town where it was 60%, it was clustered in about 3 churches. So somebody came up with the wise idea that they, talk to the obstetricians and, why. And obstetricians said, well, most of these folks, we've never seen them before. Low income, they don't have an obstetrician. They show up in the ER in labor. To mitigate risk, we do a C-section. Okay. So then we kind of laid out the data for them about why we were approaching them to ask them these questions. And they came back with, well, we have an idea. What if we worked with the priests in those churches and we did, 1 day a week, we go to St. Joe's, the next day we go to St. Alphonsus, and different obstetricians amongst us will go to these different churches, and we'll do little OB clinics where we're seeing prospective mothers, provide prenatal drugs, at least do some cursory examinations so that we have some knowledge of the moms and their conditions and their health. And within a year, that 60% had dropped to 40%, which made the overall hospital drop to 30%. And the next year it dropped from 40% to 35% as they're getting that program going. And oh, by the way, the church is happier because they're providing a service in the community that they weren't providing before. You have healthier mothers. You have less C-sections, which reduces risk for the hospital. It was a win-win-win all the way around because you had that service line data with real cost and real extra data. So that's all I have. I don't see any chat questions. If I'm wrong, somebody correct me. I'll back away to that. But you know how to get a hold of me. You'll get the recording and you'll have my email on a slide. Happy to talk in depth to any organization about what they're doing currently and how they can potentially do it better. And I'll turn it back over to the good folks in the New York HIMSS chapter.
Hey, Mike, thank you very much for all your insights into activity-based costing and sharing that story. I found it very, very interesting myself, and I hope everybody who's attending found it interesting as well. We really appreciate you sharing your expertise today. I'll wrap it up here, folks, just with a reminder, if you're interested in getting more engaged in healthcare and healthcare IT and in healthcare in New York State, please do visit themarketplace.hims.org and click on individual membership and follow the instructions there and set up an account. You'll get on all of our mailing lists, all the invites to future events, and general communications that we share. You can go and view all of our events that are coming up with links to register to those events out on our New York State HIMSS chapter.org website. So again, thank you, Mike. Thank you for all the attendees, and we hope you have a great day. Take care.
Take care, folks.